A ventricular septal defect, VSD, is a defect in the ventricular septum, the wall dividing the left and right ventricles of the heart. The ventricular septum consists of an inferior muscular and superior membranous portion and is extensively innervated with conducting cardiomyocytes. The membranous portion, which is close to the atrioventricular node, is most commonly affected in adults and older children in the United States. It is also the type that will most commonly require surgical intervention, comprising over 80% of cases. Membranous ventricular septal defects are more common than muscular ventricular septal defects, and are the most common congenital cardiac anomaly. Signs and symptoms. Ventricular septal defect is usually symptomless at birth. It usually manifests a few weeks after birth. VSD is an cyanotic congenital heart defect, aka a left to right shunt, so there are no signs of cyanosis in the early stage. However, uncorrected VSD can increase pulmonary resistance, leading to the reversal of the shunt and corresponding cyanosis. Pansystolic, holosystolic, murmur along lower left sternal border, depending upon the size of the defect, +/palpable thrill, palpable turbulence of blood flow. Heart sounds are normal. Larger VSDs may cause a parasternal heave, a displaced apex beat. The palpable heartbeat moves laterally over time, as the heart enlarges. An infant with a large VSD will fail to thrive and become sweaty and tachypneic, breathe faster, with feeds. The restrictive VSDs, smaller defects, are associated with a louder murmur and more palpable thrill, grade 4 murmur. Larger defects may eventually be associated with pulmonary hypertension due to the increased blood flow. Over time this may lead to an Eisenmenger's syndrome. The original VSD operating with a left to right shunt, now becomes a right to left shunt because of the increased pressures in the pulmonary vascular bed. Cause: congenital VSDs are frequently associated with other congenital conditions, such as Down syndrome. A VSD can also form a few days after a myocardial infarction, heart attack, due to mechanical tearing of the septal wall, before scar tissue forms, when macrophages start remodeling the dead heart tissue. The cause of VSD, ventricular septal defect, includes the incomplete looping of the heart during days 24-28 of development. Faults with NKX2.5 gene can cause this. Pathophysiology: during ventricular contraction, or systole, some of the blood from the left ventricle leaks into the right ventricle, passes through the lungs and re-enters the left ventricle via the pulmonary veins and left atrium. This has two net effects. First, the circuitous refluxing of blood causes volume overload on the left ventricle. Second, because the left ventricle normally has a much higher systolic pressure, 120 mm of mercury, than the right ventricle, 20 mm of mercury, the leakage of blood into the right ventricle therefore elevates right ventricular pressure and volume, causing pulmonary hypertension with its associated symptoms. In serious cases, the pulmonary arterial pressure can reach levels that equal the systemic pressure. This reverses the left to right shunt, so that blood then flows from the right ventricle into the left ventricle, resulting in cyanosis, as blood is bypassing the lungs for oxygenation. This effect is more noticeable in patients with larger defects, who may present with breathlessness, poor feeding and failure to thrive in infancy. Patients with smaller defects may be asymptomatic. 4 different septal defects exist, with paramembranous most common, outlet, atrioventricular, and muscular less commonly. Diagnosis: A VSD can be detected by cardiac auscultation. Classically, a VSD causes a pathognomonic hollow or pansystolic murmur. Auscultation is generally considered sufficient for detecting a significant VSD. The murmur depends on the abnormal flow of blood from the left ventricle, through the VSD, to the right ventricle. If there is not much difference in pressure between the left and right ventricles, then the flow of blood through the VSD will not be very great and the VSD may be silent. This situation occurs a. in the fetus, when the right and left ventricular pressures are essentially equal, b. for a short time after birth, before the right ventricular pressure has decreased, and c. as a late complication of unrepaired VSD. Confirmation of cardiac auscultation can be obtained by non-invasive cardiac ultrasound, echocardiography. To more accurately measure ventricular pressures, cardiac catheterization can be performed.